Good afternoon, everyone. Today's module, we will learn about how to take subjective assessment in a patient with musculoskeletal condition. So to start with, we should know the technique in what format we are going to take the assessment, which is a subjective one. So first, the pattern goes with subjective, objective, assessment and planning, where in subjective assessment, you talk about the patient's age, name, gender, how the patient's pain behaves, what are the aggravating relieving factors, the total subjective in the patient's words. Objective assessment is all about how do you assess what the patient has told you, whether they have reduced range of motion, how much pain they have, how much strength they have. So you need to quantify those all details under the objective assessment. Finally, after you have assessed the other details, we will plan for a management. So the format goes into SOAP. Regardless of which method we use for assessment, the examiner should be able to establish a sequential method so that nothing is overlooked. So a subjective assessment, the prerequisites are a quiet environment, free from distractions. You need to introduce yourself to the patient. It's always nice to introduce your name and what is your designation so that you build up a good rapport with the patient. Inform about the objectives to the patient, why you are here, what you are going to do. Because patient is totally naive. He doesn't know why the therapist is going to touch. What are these equipments for? So you need to introduce everything prior touching the patient. Remember, there should be one question at a time. When you are asking something as a part of history, do not bombard the patient with all the questions. Go one at a time so that patient takes time to understand your question and they can give you an appropriate answer. There should be open-ended questions for narrative information. Questions like, how did it happen? How did you develop this condition? Those are open-ended questions where let the patient narrate the entire story of how did he develop a certain pain. Close-ended questions should be very specific when you're asking only yes or no. Something like, do you have night pain? Do you have morning stiffness? So yes or no. Those are known as closed or direct questions. Now when we're talking to the patients, it's very important to understand the red flags. What are the red flags? Red flag means certain signs and symptoms where we as a therapist should understand this patient cannot be handled by us. We need to probably refer this patient to some other department. So when you're talking to a patient, if a patient says, yes, I have night pain, but it's persistent throughout the night, this is a red flag. Constant pain anywhere in the body is a red flag. Unexplained weight loss, loss of appetite, unusual lumps or growths, discolored or painful feet, pain or feeling of heaviness in the chest. So these symptoms can somehow make us understand this is not something musculoskeletal origin. The origin can be systemic. The origin can be a cancer or a tumor. The other red flags can be frequent or severe headaches, changes in hearing, sudden weakness, bilateral pins and needles, fainting spells or drop attacks. So these are the conditions where when the patient says, I get these regularly, you need to understand that this is not something of musculoskeletal origin and we need to refer these patients to some other department. Starting with the demographic data, name has to be understood, has to be noted down. Age of the patient, because there are so many conditions which is age specific. Say any patient above 50 years old is bound or is commonly going to develop osteoarthritis or osteoporosis. Legg-Perthes disorder is seen in younger age group. So there are conditions which we can understand OA knee cannot happen in younger patient. Rarely. So OA knee will happen only in older age because it's a degenerative condition. So age specific conditions are there. Gender, there are so many conditions which are inclined towards one gender. Say sacroiliitis. Sacroiliitis is inclined towards patients with post-pregnancy symptoms, or ankylosing spondylitis is also inclined towards female patients. Next we have IPOP number for proper documentation. About the occupation, what does the patient do? What is occupation? Because there are occupation related conditions a patient can develop. Next, hand dominance, so that we understand that if the patient is right hand dominant and he also has shoulder pain in the right side, how much difficulty he is getting during his day-to-day life. If I am a right hand dominant but I have pain on the left side, I am still going to be able to manage the day-to-day activities. But a patient who has right side shoulder pain and say he's an artist, he's a painter or he's a writer, so that will cause him more difficulty because it's a dominant side. Next, we have to talk about the chief complaints or the presenting complaints of the patient, which means why the patient is here to you, why he has come to you, what brought the patient to you, what is his problem. And when you talk, why are you here, what is your problem, the chief complaints documented by the therapist should be in the patient's own words. If he says, I have pain in the right shoulder, also I feel tingling numbness in my arm or hand, you will have to jot down the points as the patient talks. So the example goes like this: pain in left shoulder, stiffness in right wrist or hand, difficulty in lifting heavy objects, pain and inability to do household work, pain in walking, standing, bending, can't sit for long hours, and so on. So whatever patient tells you in his own language, that becomes the chief complaint of the patient. Why is he there in front of you? Next important method starts is history. History is purely narrative. It contains a lot of open-ended questions where you give the opportunity to the patient to talk about his condition in detail. What is the chronology of the entire condition? That is to be noted in the history part. So history is an extremely important step. It helps in developing good rapport. You need to understand what patient is trying to say. Take time to listen what he is saying. Be empathic, because if you're not being empathic, the patient may not develop a good rapport with you and he may miss on certain very crucial points which will lead to a good diagnosis. Look interested. So listen and understand are the two key points of a good history taking. Coming to the history of present illness, again, you need to be caring, yet professional, have an active listening attitude. It enables us to know the type of personality, language, and cognitive ability of the patient. History of present illness. Now in this, you need to ask about the present condition. So if a patient has come to you today, you will have to ask that how did it start? Predominantly the mechanism of injury, how the pain started, what the patient was doing all this while once the injury had occurred, whether he did self-medication, whether he showed to any other doctor, and during the time of injury, how the position of the joint or the structure was maintained. So the therapist must try to determine direction and magnitude of the injuring force and how the force was applied. So say if a patient comes to you with anterior shoulder subluxation, so the commonest mechanism of injury to develop that is shoulder at 90-degree abduction and external rotation. So that's how the mechanism of injury is identified. If a patient develops subluxation or anterior dislocation, this is the commonest mechanism of injury. So the patient should be able to tell you that I did something like this and then I got subluxation or dislocation. So this helps us in understanding what structures were destroyed, what condition the patient could have developed. Ask and mention all the sequence of events, preferably with dates. So if it was an accident, you need to ask whether the patient was conscious at the time of accident or after the time of accident, whether there was a nasal bleed, how did the accident take place, so that you know that what all structures could have been damaged. So level of consciousness, nasal bleed can tell us that there can be probable head injury also, along with any other musculoskeletal injury. What was the position of injured limb at the time of injury? So this is very important. So say if it's a fracture case and patient had a fracture of both bones of forearm. So if the patient were not stabilized enough, he had kept in a very abnormal position, that will also tell you that the position of the limb at the time of the injury. So whether it was stabilized or not, or whether the injury was severe, that can be understood how the patient was brought to the hospital. Coming to the body chart and pain history, this is very important part when you are going to diagnose a musculoskeletal condition. So we need to talk about the area, the onset, type, depth, constancy and duration. So area means where are the symptoms. So you have to ask the patient where exactly do you have the symptom, that demarks the area. Onset, how did the pain start, whether it is gradual, it is sudden or insidious. So gradual means a patient says that one fine morning I had a slip and then I was alright, but after 2 hours my pain started. So it was a gradual onset of pain. Sudden, I had a fall and pain immediately started like a trauma, so that's known as a sudden onset. Insidious is patient does not understand or does not remember how the pain had started. Insidious onset where patient cannot tell you how my pain started. Type of pain is diffuse, dull aching, local or sharp. So which means that different structures will produce different types of pain. So if it is diffuse, it can mean about a muscular pain. A dull aching is about a muscular pain. Local can be more of bony symptoms. Sharp can also be about bony and ligament. So different structures will produce different type of pain. Depth of structures, whether the pain is deep or superficial. By this we can identify whether the structures which are causing issue are deeper or they are superficial. Next is constancy of symptoms, whether the pain are constant or intermittent. So generally constant pain is more acute, more inflamed conditions. When you have an acute injury, when you have a recent injury, the pain is more constant. But as the pain acute symptoms reduces, when you enter into subacute or chronic, the pain can be more of intermittent. After that, duration of the symptoms, whether the symptoms are acute. Acute means the symptoms can be anywhere between 1 to 7 days, followed by next 15 days in subacute phase, and more than a month, the pain symptoms are known as chronic.